Thank you for joining us. I'm University Health President and CEO Charlie Shields, and I'm standing in front of our brand new neonatal intensive care unit. This is where our tiniest patients receive extra special care. Each time a baby is born at University Health, a lullaby chimes throughout the medical center. It's always a great moment. But at University Health, we know there are countless critical moments in the months leading up to your baby's delivery. In recognition of Black Maternal Health Week, we have brought together our highly trained physicians along with a psychologist to talk about your health from before your pregnancy until after you bring home your baby. Again, thank you for taking time out of your day to join us, and thank you to KSHB 41 anchor Dia Wall for moderating our event.
Hello and welcome to this Power Hour dedicated to healthy pregnancies and childbirth. I'm your moderator, Dia Wall. I'm an anchor at KSHB 41 News, but my most important job is I'm a mom to two beautiful kids, Alina and Evan. Black Maternal Health Week started on Tuesday and it runs all the way through April 17th. While this hour is for pregnant people of all color, we know that Black women face a maternal mortality rate that is death during pregnancy or the 6 weeks after that are 3 to 4 times higher than the average in this country for white women. So we'd like to talk about why and how to change it. This hour is going to be divided into 2 parts. During part 1, we'll talk to board-certified OBGYN and maternal fetal medicine fellow, Dr. Tracy Johnson. We've already had a little fun chat started already, and she's joined by women's health psychologist, Dr. Tiffany Ruffin. During the second hour, we'll hear from maternal fetal medicine specialists, Dr. Davika Malik and Emily Williams. If you have questions for the docs, feel free, type them in the chat section. Y'all know I am not the expert, but I am so happy to be here to talk with them. Welcome, ladies. How you doing?
Good.
Good. Let's just start by kind of setting the table. What is the importance of Black Maternal Health Week?
I think it's interesting to talk about the fact that people, lots of times when we separate out a separate group, it feels like another group is being lessened. But the problem with this situation is that when we look at the entire cohort of pregnant women and birthing people, there are certain people that are having different outcomes. And so if we don't focus on that, they're kind of lost in the shuffle and lost in the narrative of what's going on. So that's why it's so important is to focus an entire week on people that not necessarily are doing anything differently, but receiving care and having different outcomes so that we can make sure that we're doing something about that.
Now, Dr. Ruffin, you work in the high-risk pregnancy clinic. What is it like when you layer in the components of being, right, a Black woman where outcomes are already, worse than they are for our white counterparts? And then also the psychology of being in a high-risk pregnancy.
Yeah, it's such an interesting experience, and I feel so honored. I think honored is the best word to use to describe how I feel being there. So being able to be a part of someone's journey in that experience and be one person who's able to come into that room and say, I hear you, tell me more, and sincerely sit with someone and hear what they're trying to say that maybe they haven't been heard before. And even if they're not able to say that to other people, I'm able to help bridge that gap and share with the wonderful OB providers that we have some things that I'm seeing. And recognizing that there's this connection between mental and physical health that sometimes we want to separate the two and we're still trying to separate them, and recognizing they're all the same. When we're talking about health, it's so important to recognize physical and mental are together.
Just a quick follow-up there. How do you kind of preach that to the broader collective, right? Whether that's your OBGYNs and your specialists here at University Health or out in the community. Really just going back to what Dr. Johnson was talking about. It doesn't mean one group is better, right? Or a higher importance is placed, but this is really about equity in a sense?
Absolutely, equity, perfect word for it. Talking about the equity over and over. Even if people don't want to listen, you keep talking.
That's right.
I think I'm talking to the people here who know all about that.
Oh yeah.
And you continue doing the things that you know are right. You continue using your voice to elevate those voices that need to be heard. You continue to say over and over again the importance of listening. I think that's number one thing when we talk about any healthcare is listening to the person in front of you, especially when it's a group that doesn't always get listened to. Paying attention and listening to what they're saying, listening to what they're not saying.
That's a word right there, Dr. Ruffin. Dr. Johnson, why are Black women dying at just higher rates in general?
Dia, how much time did you say we have? Right.
About 60 minutes, but
right.
you're only in the first half. So
okay. I just want to be clear. It's harsh and people don't like to hear it, but just as Dr. Ruffin said, it's institutional economic racism, systemic racism. And so again, that makes us all feel really yucky, but there's a couple things that we always want to underscore. Number one, if you look at the literature and you even look at old imagery on television, what we picture when we talk about Black maternal health and mortality is they're more obese, they have hypertension, they are older, they have more children, and that they came into pregnancy sicker. What that is what we call shame blame, in that it's her fault that she is not able to have the same outcomes. We actually know that they're not necessarily more obese all the time, they're not necessarily fraught with diabetes and hypertension, and it's how they're actually interfacing with the medical establishment. So number one, how they show up in the space and how they're treated in the space. I'll talk about a little bit about that in a second. But also, there is something going on to people that can be vulnerable, especially Black women, and it's something we call weathering. So I'd like to take 2 seconds just to make sure we understand what this is. Weathering is twofold. Whenever you have a physiologic reaction to stress, maybe you were evicted, maybe a tiger is coming after you. The same thing happens for both of them, and that is your body is gonna elevate their cortisol, you're gonna have an elevation of epinephrine, and you're gonna feel like you need to run, you're gonna feel like you just exercised. What happens after that is you're gonna come down off of that, and you should kind of chill again, right? You should be okay. But then after constant chronic stress, your body's going to react in a number of different ways. It may actually stay high, where you're always in this fight or flight. So now you're going to have higher cortisol levels. That can change metabolism. It's easier for you to get diabetes. Maybe you have some obesity that's happening now. You process food and diet differently. But also, you may increase your inflammation. So what's going to happen with that? Now you have women that are young with lupus. Now you have women that have breast cancer at 30 years old when that should be after 40 or 50 years old. Why are Black women having things that they should easily fix, like a small infection, or things that they shouldn't have because they're young, way higher? It's because they're in this chronic stress situation, and so their bodies have to weather that, but then also they're weathering against all these constant insults. When I bring that back to maternal mortality, the reason why it's important is because you may have a 30-year-old woman who's maybe my size. I'm regular. Do I need to lose 10 pounds, dear? I do. But my husband thinks I'm fine, and I think I'm fine, so it's not that bad. I have a little bit of hypertension, I mean a little bit, and I am 44 years old. Now, I should be able to go through pregnancy, and it shouldn't be that big of a deal. But now, I might actually have a heart attack because of chronic stress, especially when I have more degrees, I have more on my plate, I have people that may tell me that I'm not enough, not a University Health, they tell me I'm enough, but I may have this constant everyday interaction with the United States of America and systemic racism, and so people go, doctors don't get up every day to tell that patient that she's not enough and that she's not going to get the same care as this person. We don't wake up in the morning and go, I'm going to treat Dia different than I treat Dr. Ruffin. Nobody does that. It's secondary. It's what's coming on from the outside, and then it's subtle. It's the fact that maybe you have hypertension, and I expect you to have that, so I might not treat it as aggressively. So all those things are at play, and then you may come through pregnancy with a very small infection, and because of everything else you're dealing with,
it's exacerbated.
It's exacerbated, and one little antibiotic, you die from sepsis when it should have just taken one antibiotic. Does that make sense?
100%. 100%. I think one thing, especially when you talk about institutional racism, I think there's often this misnomer that comes from ill intent.
It doesn't.
Right? And some of that has been institutionalized for generations.
That's
and
right.
so the idea there is that it's already existing, right? It's foundational. It's in the underbelly, and we all contribute in some form or fashion to that. Mm-hmm. Dr. Ruffin, what role does mental health play in maternal mortality?
Such a great question, and I think it really highlights everything that Dr. Johnson has been talking about already, in addition to recognizing the interplay again between mental health and physical health. So one thing that I would piggyback off of what Dr. Johnson just shared is when we think of this experience of this person coming through and interacting with a day-to-day life of all of this stressor. So it's this chronic stressors, this racial stress, as it's been called as well. Mm-hmm. And then they show up to their appointment. Well, understandably, they might have some anxiety. There might be some things that they're expecting also at that visit based on their past experiences in the healthcare system. And so now they're showing up with this elevated heart rate, right?
Yeah.
Blood pressure's a little high. And so they're feeling anxious, and then they're not able to communicate in the way they would like because they're anxious, and maybe because of the responses that they're getting. So they're not sharing their concerns, or their concerns aren't being heard, even if they are shared, because maybe someone's already expecting this to be related to other things. So we're missing something. And then maybe they're not coming to that next appointment because that last appointment wasn't very good, and that's going to be really hard to talk to me and go into this next appointment and have this experience again with the same old, same old. And so they're less likely to show up. They're less likely to feel heard and have a good experience and feel like
Maybe they have a different provider.
Yes, different
and you got to
provider.
start over.
Tell the same story over and over. So now I feel traumatized over reliving these things that I keep saying. Do they not hear me? Do they not care? Not understanding why they're asking this. And so now I'm anxious, and now I'm more anxious. And now I just heard them say some other medical thing I need to go home and look up and figure out what that means for me. And so now there's this perpetual anxiety building up, healthcare anxiety getting worse and worse. And so now we have mental health that's not being treated or addressed because we're focused on this or this and not recognizing that now we have anxiety to deal with as well. And so now the mental health is playing into this as well. And then we talk about postpartum visits. Not coming to the postpartum visit, maybe I had a really traumatic delivery experience. And that is, I think, really important to acknowledge because it doesn't have to be medically traumatic also to be traumatic.
That's right.
And the most important thing is that person's experience. If it was traumatic to them, doesn't matter how it went from a physical standpoint, it was traumatic. If they didn't feel heard, if they didn't feel listened to, if their voice wasn't in that room in the way they needed it to be, it could be very traumatic. And now we're expecting them to come back in 4 weeks to tell us how you've been doing. Might not happen. And so that mental health component is real. It's all intertwined, and it's going to impact the care that they get and the ability to hear the information that they need to hear and feel like they can use their voice the way that they want to.
You know, I think it's also important to let people know this goes beyond feelings. We're talking about maternal mortality. We're talking about
death.
Pregnant women, brand new mothers dying.
Yes.
And the stigma of getting that mental health check-in and help and assistance, whether that's therapy or even taking those things a step further, the stigma is definitely different in the Black community per se than it is in some others. How do you fight that?
I think it goes back to
hard.
to the number one thing, right, is recognizing it's hard. I'm certainly not going to pretend to be an expert in knowing how to fight that. But what I can share is the importance of listening. It goes back to listening to these voices, listening to what they're saying, not just listening, but validating it. Not, interesting, right? But listening and hearing their story and validating that that's their experience. It is real, it matters. And also acknowledging the stigma, right? Not trying to pretend and dance around it. Like Dr. Johnson mentioned, this stuff makes people uncomfortable. Get comfortable being uncomfortable. Talk about it. I recognize that there could be a stigma here. People often will share the stigma of the strong Black woman, right? Like we don't talk about that.
Did you bring your Superman coat?
Look, I'm nobody's.
Because I didn't bring mine.
You know, I've had people
left it
ask
at
me
home?
before, you know, how do you do it all? I'm like, I don't do it all. And I for sure don't do it all on the same day either. You know, does that mean that you have to seek out, Dr. Johnson, providers as Black women who look like you?
You know, I love that question. I love that question because there are, I think, 6 to 7 OBGYNs that are Black in the city that deliver, I think, are a little bit less. And that's both sides, Kansas side and Missouri side. So, Dia, I cannot deliver all the babies, even though I love it. It brings me joy to deliver kiddos. I cannot deliver all the Black babies. Now, here at University Health, we deliver more Black babies than anybody else in the city. We are proud of that. We love that. Every single person on our staff, I can attest to that, loves that. However, Dr. Johnson with the brown face and a lived experience cannot do it. So what I think is the whole reason why we say that is the shared experience is listening. I think that the idea, especially in the literature, is really hot right now to have someone that is congruent with you. If you have an LGBTQ patient, maybe we should find an LGBTQ physician. If you have someone who is a male, they might want a male. So that's very hot, and we do want to do that when patients are able and they request it, but there's not enough of us. So number one, pipelining needs to be better, right? We need to go way back to, it would take kindergarten for Black males. You'd have to change things at kindergarten in order to increase that pipeline. Yeah, we'll talk offline about that. That's a big thing. Second, it would be to understand that I cannot do it all, but why do patients want me? It's because they're listening. So one, all providers need to say, hey, what is Dr. Johnson saying that makes patients go to Tiffany Ruffin and get mental health when she didn't want to do that anyway? But then also, you need to find a doctor or a clinician who listens to you. And if you don't, we say all the time, get a second opinion. Switch to somebody else. You do not stay with somebody you don't trust. There's ways to figure out if you feel comfortable. If you ask your physician or your clinician, if I don't do that test, What's going to happen? What are you going to use it for? What happens if it's negative? And then what happens if I don't do it? If they kind of pop off, switch to a different person. They should be asking you questions and they should be educating you. So just switch. But I can't do it all, even though I'd like to. I can't do it all.
You know, I do think what advice would you give somebody, right, who's pregnant? We all know you got about 400 appointments when you are pregnant, right, ideally. And there is a relationship that's built between expectant mother and an OB. What would your advice be when you're seeking out that provider who's going to be partnering with you through your pregnancy?
I'll tell you what I tell my family. So you're from Texas, I'm from Texas.
Yes.
My family calls probably every 3 weeks with something that's medical because, you know. And so what I tell them is, number one, who's the person and how did you find them? And if someone referred them, that elevates whether we trust them or not, right? I learned this wonderful saying the other day. I know you're going to love this. Trust is lost in droplets. It's gained in droplets and lost in buckets. And it says so much. Ever since I learned that a couple days ago at another conference, I was like, that's exactly what's happening. So if someone else trusts them, you're gonna go, okay, that ups the ante a little bit. Do they listen to you? Do they ask you questions like this? Or are they actually saying, tell me your story. What's going on, Dia?
Yeah.
Tell me about your birthing story. Oh man, that was great. That wasn't great. Are they partnering with you? When they give you options, do they tell you what to do or do they give you the smorgasbord? Do they say you have option A, B, C, D, E? Let's take off A and E because those are probably not great for you for these reasons. And then that leaves you with B, C, and E. You tell me which ones you want. We can try something. We can move on if you don't like it. It is a partnership, something in medicine we call shared decision making. If they're not doing that, go to the next person. A lot of times Black and browns, they can't or they don't feel like they can, either because insurance has bottlenecked them, access because they can't get there because it's on the other side of town, or just not knowing that they have agency in it. I find that a lot. People go, I didn't know I could have went to Dr. Malik. I had no idea. I'm at Lakewood. Actually, she's there on Tuesdays. You just didn't know.
Right, right. It used to be called postpartum depression, Dr. Ruffin. And now it's, let me read this so I can make sure I get this right. It's perinatal mood and anxiety disorder. So, one, what's the difference? And two, if you could talk to somebody who maybe has a new baby and is like, oh no, I feel like I should be overjoyed. But I think sometimes that the stigma or the perception or the overall assumption is like, if I don't feel like caring about my baby at all, that's when you get help. But I feel like there's a spectrum there.
Absolutely, absolutely. So the shift from just talking about postpartum depression, we now call PMADS for short, easier to remember that way. So the perinatal mood and anxiety disorders recognize that these symptoms can start anywhere from conception all the way to at least a year after delivery, and it can still be related to that baby experience. And so we want to recognize that entire experience. It's also not, quote unquote, just depression. We want to give space for the anxiety that's a very real thing for many people. So that's the constant worry, the checking, the not being able to sleep, not just because you're sleep deprived and you got a baby crying, but your mind won't turn off. Thinking of all the stressors that you're dealing with all the time, all of that's keeping you up at night. In addition to that, it can be rage and irritability, and I just don't feel like myself. People around me are saying I don't seem like myself. That is all symptoms of this perinatal mood and anxiety disorder. Alerts to talk to your provider more about those. And you know, ideally we don't want to wait until it gets to that place that's so far. If you're not feeling like yourself, you're the expert. If you're going to that appointment and they're minimizing, oh, pregnancy's hard, having a baby's hard, just like Dr. Johnson has said, get another opinion, because your voice, your experience is what matters here. And if you're feeling like you're not yourself and you're not sure, talk to someone about it. If there's providers who you're not connecting with or not feeling like you're getting the information, there's some other online resources, building a sense of community through online support groups, other ways to get connected with other people who are going through this and are going to hear you and see you.
I remember when I had my first daughter, you feel like this crash, right? Is that a biological thing that happens?
It is.
Because I feel like you're up on life. You know, the endorphins are flowing. You got this baby that's coming. All things are great.
She's super cute.
Oh, 100%.
Oh, I know she was cute.
And then you feel this crash. How much of that is biological and physical, and how much of that is also mental and emotional?
So I would say
both.
both. Yeah, goes back to not being able to separate the two fully and recognizing they're both there together. Absolutely.
The hormones fall, and then you're tired. And for some reason, My husband just wouldn't wake up. I don't know what's going on,
First
Dia.
of all, can we talk about
It's
that?
like the husband was right there and he's next to you, but you hear him, but you don't hear him, Dia.
Oh yeah, I'm gonna have to put this husband on blast.
I'm telling you, he's amazing. He's amazing until that baby went to sleep at night.
And the baby's in the bassinet right
Right
here,
there.
and you are getting the best sleep of your life. I digress.
Okay.
Yeah,
Okay.
yeah.
Let's just, okay.
Now, when it comes to starting to turn the tide, we've been talking a little bit about some unique things, a unique program here at University Health that's dedicated to maybe changing how women go through pregnancy.
Yeah,
Tell me
we
more.
are so excited about the Elevate Group Prenatal Care Project. It is not our inception. It's with our buddies over in WashU in St. Louis.
Okay.
Actually, someone that I went to residency with, she was my best friend in residency. Our children are betrothed together to get married when they're older.
That's not gonna work.
Yes,
That's
it
not
is.
gonna
Yes,
work.
it is. It is a thing. And they actually found that their preterm birth, low birth weight, and postpartum depression rates were very similar to a lot of the worst parts in the country, and they're actually extremely similar to Kansas City. What they did was, and with a typical pregnancy, what you would experience in the United States is to go through and see one provider or maybe a couple providers every single month until the end of pregnancy, like we talked about. At the end, you'd go every 2 weeks, and then closer to delivery, you'd go every week, and that's to pick up things that happen towards delivery. You would typically spend about 15 to 20 minutes with that provider. So over the course of your whole pregnancy, 40 weeks long, you may spend 2.5 to 3 hours, not including your labs and ultrasound. During those appointments, you're learning some small tidbits. Back in the day, we used to be able to sit down and teach you everything about breastfeeding because there were midwives that were more utilized, there were nurse practitioners, there was a whole Lamaze and prenatal classes like we talked about. That's all gone away. So the community is lost. Other cultures do prenatal care in a group setting. So you may actually have people that are going to deliver between October and September. They may actually go together with about 10 different people, and they go through pregnancy together. They're learning. They have growing pains together. They're excited about whether they're finding out boys or girls. And so then what happens is, here at Elevate, we have not only done the group prenatal care model specifically for people at high risk for postpartum depression, low birth weight, and preterm birth. So that includes people that have public insurance, people that are Black and brown, people that are single or had an unintended pregnancy,
Or high risk,
people
potentially.
high risk for depression or already have depression. So all those patients that we know are the highest risk, we allow them to go through pregnancy together, and they love it. To the point where yesterday we saw 4 patients, and they were like, "Are we having a reunion?" And we were like, "So we got to figure out how to get some money for the reunion." And they were like, "Cause I got to show her my baby, and she had her baby after me, and I didn't get to see her baby." I mean, to the point where we have to figure out how to do that because
them engaged.
they want to continue. And so what it does is not just going through prenatal care on its own, but we've embedded toxic stress eradication and mental health within it. So how do you advocate for yourself? How do you do mindful eating? How do you make sure that when you have aches and pains, you can do so, you can fix it in a way that's helpful for you, but you can also identify where the issues are. And our rate of preterm birth is less.
Give me the numbers.
So in the pilot in St. Louis, normally it would be about 7 out of 1,000 people in the country deliver preterm. So that's before 37 weeks.
Okay.
Infant mortality is 100% related to maternal health and preterm birth, right? So when I say 100%, I mean that's the largest share. There are other things like a baby has a problem, infection, things like that. But most of it is maternal health and preterm birth. So 7 out of 1,000 of all patients that are birthing deliver preterm. It's about 7 to 8. For Black women, it's about 14. Double. So
Make sure I just want
that.
to put
Thank
the
you very
exclamation
much.
point on that.
Thank you
Okay.
very much. And in Kansas City, 18 to 22. 18 to 22, and the same for St. Louis Urban Core. So in St. Louis, they had only 1 in the pilot deliver, and it should have been 18. Actually, it should have been 7 because of the cohort was smaller. And in women who had already had a preterm birth, which is your highest risk for preterm birth, they didn't deliver preterm the second time. They love that program so much, they work for the program now. Yeah, they
So
teach
what were
people.
the numbers here for you guys?
We're not all the way done, but we've only had 1. So I know it's better, but I can't technically say that because we don't have enough numbers to prove it for sure.
What is it like putting in a mental health component with a program like this?
Well, I think this really highlights what you were asking earlier with the stigma, right? Because when we have groups of people going through this pregnancy experience together, and it's a normalized part of the treatment, as it should be, because again, mental and physical are connected, then it becomes not stigmatized. This is just part of your health care. And that's one of the advantages, too, of when we have behavioral health services integrated in a high-risk clinic where I'm able to come to them. They're not making a separate appointment. I'm just there because we know that this is needed. It's part of your overall health care. So it decreases that stigma, and it increases the conversations that we have to be having.
So your appointment, I don't know that I made this clear. Your appointment, you spend 5 minutes with the midwife doing all the private things like measuring your pregnancy, measuring the heart rate, but then you go out to the group and you do all the education together in 90 minutes as opposed to 15 minutes with one provider. So that's why everything is together when you're talking about things and educating yourself, and you do that the same 13 appointments that you would have for individual. Sorry, I forgot to say that.
No, that's fabulous. This has been so much fun. If there was anything that you would want our broader community to know as we are in the midst of Black Maternal Mortality Week, what would it be?
Number one for me would be listen to the Black moms, listen to the Black people in your life sharing their stories, listen to what they're saying, validate it, and know that there are great resources even here in Kansas City that are really important to know about. So as other people, if you're not that provider that they're going to, know your resources that you can send people to. So know what those are.
For Black birthing people, I would say you don't have to just be happy to be here, and you don't have to smile and just go along. It's your body, you have autonomy, and you have agency. So if someone's not listening, just like you said, on the patient side, if someone's not listening, if you're not getting your needs met, you can call us, you can call some of our friends. If you're here and you want to talk to a different person, we are totally fine with getting a second opinion, because it is all about you, getting you through your pregnancy so that you can be safe and have a healthy entire life course, because pregnancy is a window into later life.
Shout out. Dr. Ruffin, Dr. Johnson, thank you so much for this and for sharing your expertise. All right, coming up after the break, learn more about a chronic and all too common disease that's putting pregnant people at risk, and more importantly, what physicians are doing to help.
About half of all babies born in Kansas City, Missouri are delivered at University Health. With 4 high-risk specialists on staff, doctors from across the region refer patients to University Health. While the goal is always a healthy baby, we know that some of our tiniest patients often require extra special care. I'm standing inside our new state-of-the-art Level 3 Neonatal Intensive Care Unit, or NICU. This new space made up of individual patient rooms allows families plenty of room to be with their newborn. If a baby needs the highest level of care, Children's Mercy Kansas City is just steps away, thanks to the brightly colored Bridge of Hope. We recently caught up with a Kansas City educator who wanted her whole life to become a mom. But at age 40, she knew she needed high-risk care right from the start. She received that care here at University Health.
When I first learned I was pregnant, I was ecstatic. And I was just like, oh my goodness, like shocked, happy, anxious, scared. I am grateful for the team of doctors that I had with University Health. It was a feeling of peace. I don't have a medical degree, so the fact that she was able to break things down for me in layman's terms, I appreciated that. She's a joy. She's a complete joy, and I'm grateful that I have her. The care that I received here at University Health was unmatched. I never lost hope. You know how you take a deep breath and you go, finally, yeah.
Welcome back to this fantastic Power Hour as we're talking about healthy pregnancies, healthy births. So we had a little quick change in the break here, and I'm joined by 2 amazing specialists, maternal fetal medicine specialists, Doctors Davika Malik and Emily Williams. Thank you both for being here. You know, what do you believe is the most important piece of Black Maternal Mortality Week as we are really talking about ways to have healthy moms, healthy babies?
I mean, I think Drs. Ruffin and Johnson alluded to a lot of it already as far as making sure that we are incorporating things like shared decision making and really having an open dialogue with patients to make sure that we are hearing their concerns and the issues that they're facing in their pregnancies so that we can best work with them to improve pregnancy outcomes.
Dr. Malik, what do you see as some of the biggest barriers to achieving those outcomes?
Well, I think it's trust. Trust is a big issue. You know, when you're dealing with a situation like this, was it just, as you said, it's not about thoughts and feelings, it's not about tears, it's about devastated families, it's about loss that cannot be undone. And I think we have to understand that as a society, that this is something that we're all part of, no matter where you're from. If you're in this country, you are part of this problem. And I think we all have to do our part to try to eradicate that problem.
Dr. Williams, you focus on all high-risk pregnancies, but you work with folks specifically with diabetes. In what ways does diabetes impact maternal mortality?
Diabetes impacts all components, all facets of pregnancy, from the beginning of the prenatal care throughout pregnancy through delivery, and has implications postpartum for both mom and for babies. Diabetes puts a tremendous amount of strain on the maternal body. It poses risk of progression of organ damage to several systems, the neurologic system, vision, heart problems, kidney problems. It really extends to everything, and that doesn't stop during pregnancy. And so that's why we like to follow moms who have diabetes pretty closely to make sure that we can work to get the control of their diabetes as well as possible to promote long-term health for moms and also for babies who are at risk for issues as well.
Dr. Malik, your trademark is that pregnancy is a stress test for the body. Explain what that means and why it's significant.
Well, the way I like to put it is you're doing something that's kind of magical. I mean, I know that as doctors we try to avoid that word, but it is kind of magical that we're growing a different human being in our bodies. And it is really, truly something to celebrate that birthing people can do this. But as a result, all the resources that are usually keeping your body afloat and functioning are all going to this growing human being. And so a lot of things that might be percolating right below will come to the forefront. So if you get blood pressure when you're pregnant, you're more likely to have heart disease later on in life. When you're diabetic, when you're pregnant, you have a 50% lifetime risk of having diabetes later in life. And I usually like to think of that as not as something that we need to be scared of, but as an opportunity to learn about our bodies so that we could try to prevent, because there's so much opportunity for prevention and in getting basically healthier families, both at the birthing person level, but also, you know, for their families moving forward.
We often talk about pregnancy as a window into future health, particularly for those reasons. It gives us an idea of what sort of things we might be dealing with in the long term in that birthing person's life, but also gives us a unique opportunity to work to improve their health in the future too.
But that is scary. I mean, when you find out that you're growing a life, everything, you want to eat better, you want to be healthier, you want to walk a little more, make sure you hydrate, all those things, right?
Well, speak for yourself. I lived on red drink and Doritos infamously when I was pregnant.
I did eat more ice cream than usual. But I mean, I think there is that fear, right? Because at every appointment, you know all these milestones matter for yourself and for baby. How do you coach people through like you said don't be afraid of this news, but what is the importance of us making sure that we have our expectant moms coming in, getting the testing done, and really being able to talk through those results and what that means for them, their current and future health, as well as the babies?
Well, what I like to say is that it's so easy for doctors to make recommendations, right? But to put those recommendations in the context of real life is a whole different story. And I tell every patient, I'm giving recommendations I would give to you, like to myself or to a family member, and just like a family member, you can say no and disagree with me. And so I believe that while we know a lot in medicine, there's a lot we don't know. And the most important thing is that we try to have some solution that is constructive and that's doable. And so they should never look at us as people who are about to make judgment and give bad news. We're here to serve our patients and our communities. And so if there's something that we're saying is not sitting well, or they don't like what we're recommending, they have to tell us that, and we will work together. I always say it, you don't have to listen to me. I infamously say actually in my clinic that we're not fascists. You know, that we're here to actually listen and to figure out solutions together.
Again, to echo Dr. Ruffin, a lot of it is about validating experiences also. We recognize that a lot of things that we ask people to do in managing their pregnancy, particularly for diabetes, can be really difficult. There are a lot of additional steps that they have to take during a very high stress period of time. And so acknowledging that it is stressful and that we are asking for a lot, I think is helpful. And working as a team together, I always tell patients, these are the things that you can control and why we care about them. Anything else is my problem. You don't have to worry about it. The rest of it's on us because we're a team to work together to help get you to where you want to go.
When you are interacting with patients, right, and you're layering in some of those risk factors in addition to like the diabetes, you know, what is your best course of action? Because I do kind of want to put people at ease. And even if you do have diabetes and you're coming in and you're pregnant, again, it's not something to fear. I want there to be that opportunity to build and develop trust and kind of pull the veil back behind how you do what you do.
I actually like to lay it out at the beginning of the meeting to kind of take away some of the mystery and some of the anxiety that comes with it. We put a little outline at the beginning and say, okay, this is why your doctor sent you here or why I understand that you're coming to see you. We're going to talk about how that might affect your pregnancy, how it might affect your life after pregnancy, and then we're going to talk about what we're going to do about it to make sure that you are safe and that you have a good outcome. So we talk about, it might sound scary in the beginning, but we're going to leave with a plan so that hopefully that you'll feel comfortable by the time we're done talking, and we'll have established some trust in there too.
Is the risk of Black and white women developing diabetes during pregnancy the same?
It's very close as far as gestational diabetes goes, as far as women who do not have diabetes when they enter pregnancy but develop it during pregnancy. The most recent information from the CDC showed that white women had a rate of about 6.5%, or of 7%, and Black women had a rate of about 6.5%. So it's very close.
When you are looking at some of the data, you know, I was pretty surprised when Dr. Johnson was talking about, I mean, maternal mortality is like 7%. That's a high number.
That's a high number. I mean, that's not something that we should be okay with. We have to be like working, you know, we're behind the ball, we're behind the curve, and that we have to, like, we shouldn't even have just 1 week. Should be every single minute, life, and day. We should be constantly thinking about it. And it shouldn't just be on the medical community or even on Black communities and people of color. It should not be, it should be everybody's responsibility. This should be the first thing that even people running for office should be talking about, because policies do matter. What we decide for each other matters. I mean, this is a community effort, and we have to remember that.
Dr. Malik, why do you believe that the numbers for Black moms, losing their lives, I keep saying it, in pregnancy and shortly thereafter, are double what they are for white women in this country?
Well, how much time do you have?
Come on now.
You know, honestly, I think part of the problem is that we're seeing the downstream effects of systemic racism. You know, when
Second time that phrase has come up today.
When people have to stress every single day of their lives and fight to survive, that sort of adds up. And I remember what I said is that pregnancy is a stress test, and sometimes that stress really just comes to the surface. You know, so that's part of it. Part of it also is that there is systemic racism even in medicine. There's such a thing as medical racism. As a person of color, I've experienced it. My family's experienced it. I've also seen it happen. And it's something that I actively fight. And I'm really, really proud to work in University Health because I do think they prioritize trying to combat that and really trying to, you know, make efforts to reverse the trends that we're seeing.
What are some of the factors that you believe contribute to Black women dying at higher rates in pregnancy and shortly after?
I mean, again, just not to sound like a broken record, but really there are a lot of inequities that are built into the system within healthcare and also our society at large, as far as things like weathering that Dr. Johnson so eloquently explained earlier during her discussion, inequities in access to healthcare, to nutrition, all kinds of resources. It's really just like at every level, there are so many barriers that add up to create this big problem.
Dr. Malik, when you look at some of the concerns, because I'm sure you keep it real with your patients, I just have a feeling. When they're talking to you about their stresses and the things they're worried about, I mean, I'm pretty sure I told my OB all my business when I was pregnant about the things I was challenged with and what was hard and what I felt like was going really well. What are the common things you're hearing, and what is kind of your best advice for some of those common problems or challenges?
Well, sometimes it's like I don't have time for myself. I have to take care of a family. I have a job that I have to work on. I have no support. You know, guess what? I experienced the same thing when I was pregnant. Yeah, I mean, it's a very universal feeling. I feel sometimes if birthing people came together and formed their own political party and changed the scope of how we take care of mothers and birthing people, I think we would have a very different situation right now. But what I like to say is that it's something that everybody experiences, but it does not make their experience less or worse. And I try to acknowledge that. Then I also try to tell them that if they need any advocacy with their employer, if there's anything I can do, we try to give them resources that are outside of the scope of the clinic. Even with the social workers are our best friends sometimes. But I also understand that our communities have some distrust even of the medical system, even of social work, and I have to acknowledge that. And sometimes the solutions come from the community. I have found some of the best resources are people like Mama Hakima in Uzazi Village.
Oh yeah.
You know,
she's a legend, by the way.
well, she's a legend. She's a genius. She has grown from everything from scratch. And I have become a better physician having known her. Yes, I've become a better person. I have learned so much from her. And I think that's the thing that we have to understand as being on this side, being in a hospital, we have to acknowledge that we are up against a lot of ugly history that comes with medicalization of obstetrics, that comes with standard medicine. A lot of things that we now know about our bodies came from a very evil history, and that is true also for modern gynecology. But our duty and our goal should be to try to start a new chapter. And I think a big part of that is humility and sometimes going outside of the hospital and reaching out to those people who may be able to teach us a little bit better.
Oh, any follow-up, Dr. Williams?
No, again, I think that was eloquently stated. I really don't have anything to add. That was perfect.
I said I wasn't expecting that in the Power Hour. I do want to go back to diabetes because we know, this is something that affects especially the Black community in larger numbers. What effect does it have on your baby, right? If you are already diabetic when you become pregnant?
Sure. So very, very early on, control, we say, or how well controlled your diabetes is has an effect on whether or not pregnancy will even be successful. Women who have uncontrolled pregnancy or uncontrolled diabetes in pregnancy are more likely to have miscarriages than women who don't have diabetes entering pregnancy. Very high blood sugars in pregnancy can also affect the development of the baby's organs, and they're at higher risk for developing anatomic birth defects as well. Growth of the baby can be affected, with babies either not growing to their full potential and being too small or growing to be too large, which then can cause increased risks of injuries for baby or for mom during the time of delivery. And then after that, kiddos that are born to diabetic moms are more likely to be admitted to the neonatal ICU. They might have trouble controlling their own blood sugars after they're born. They might have higher risk of jaundice and need to have the phototherapy under the blue lights people may have seen before. And then they're at increased risk of having obesity-related disorders themselves later in life, too.
Do you recommend any pregnant person with diabetes see a high-risk doctor?
I do. I always think that it's a great idea if you have a medical condition entering pregnancy to get additional insight about what your particular challenges might be in pregnancy, and again, developing a game plan to move forward. It doesn't necessarily mean that you will have to see a high-risk doctor for the entirety of your pregnancy, but it can provide valuable input for proceeding. It also is possible for people to have a consultation with a high-risk pregnancy doctor before they get pregnant too, if they want to plan and prepare to make sure that they have the best chance of having the outcome that they want in the pregnancy that they want.
Now, what is your best advice, Dr. Malik, for somebody considering pregnancy soon? It's not me. We're done.
What I like to tell everybody is that you're not doing this alone, and you should not be doing this alone, and that you should look for all sources of community that you can find. And some of that, surprisingly, can also be at the hospital. I always say that, we see our patients sometimes every week, every other week. We see them quite regularly. I have patients who, I'm not their primary OB, but they say, I've seen you more than anybody else during this pregnancy. Mm-hmm. So you develop really strong relationships. So it can be in the hospital, but there's also a lot of resources out there for birthing people and women that they can look out for. And I also try to educate, I try to educate my patients on what I know about, and they sometimes educate me so that I can tell the next person and pass the word. So I think it's really important that we know that we're all in this together.
What's the importance of vulnerability around the risks for maternal mortality and the risks around it, really? What is the importance of making sure that we continue to talk about this, not just with each other, but also with people who are giving birth, birthing people? That's in my lexicon now.
So what was the question? I'm sorry, can you
What is the importance of us really talking about maternal mortality and what those risk factors are and how we can prevent it collectively, right? Not just with each other or in a hospital setting, but with patients and with people who are going to have children.
I mean, I think it's vital. We can't make any changes unless we're openly talking about the issues that we're trying to change. So continuing to have these conversations to remind people what a huge problem it is and how important it is, so that we can keep it in the front of people's minds, so we can continue to talk about policy change and moving forward. We talk about it all the time.
Of course. Dr. Molly?
Well, so repeat the question again. I'm so sorry.
The importance of us talking about maternal mortality, what the risks are, and
Right.
how it impacts people who are bringing life into the world. I don't want to.
Well, I mean, I think that you have to acknowledge it. I mean, there's no way not to. And I think it is a fear that a lot of black birthing people and women and people of BIPOC people are having, you know. And so I think a lot of families are scared. They don't trust the medical system always. And I think that if their doctor acknowledges that this is a problem, I think that's the first step in trying to heal that, you know, to heal that wound, that bridge, you know, to create that bridge, you know, between the medical community and the community at large. The other thing is that I, again, don't want to like keep on banging that drum, but they really are not alone. And that if they are scared, they should feel open to express that fear, and that we're here to address that. I think a lot of the stories that we hear out in documentaries and in the news, you hear the same thing: I was not heard, I was not acknowledged, I was invisible. And I think that if you acknowledge things, you acknowledge people, acknowledge their experience, that's a good first step. It's not going to fix everything, but it's a good first step.
Dr. Williams, what are some of your favorite resources? Maybe the things that people who are pregnant or hoping to, planning to try to become pregnant should know about, that you would want them to know about, things that are available here for folks.
Here?
Yeah.
Well, like we talked about, we have wonderful social work services. We have wonderful perinatal psychologists and psychiatrists. We've heard a lot about the importance of mental health and what we're doing in that area.
Had that when I might have needed it.
The addition of the Elevate program and group prenatal care obviously is wonderful, and I think has great potential to improve outcomes for birthing people in Kansas City and here, particularly at our institution. And really, again, your own community is a great resource as well. You know, your friends and your family, your mothers, sisters, cousins who have gone through the experience as well and can offer you those informed recommendations about doctors that will listen to you, or places where they had good experiences. I think that's invaluable.
What about you? What are some of your favorite resources, the best kept secrets?
I mean, I think that I work in a fantastic team. I mean, I have Dr. Williams, Dr. Johnson, Dr. Ruffin, and I think what's really special, Dr. Mundy, who's unfortunately couldn't make it with us today, but I think what's really special about our team is that we're willing to think outside the box and imagine what prenatal care could look like if we really designed it for patients and for birthing people. You know, I think there is a huge capacity for imagination here. Like, you know, how can we reconfigure what we provide to patients in a way that they are excited about and they can celebrate?
When we were just talking with Dr. Johnson about some of just the early results from this Elevate program, which I think is very interesting, right? And I really want to dive into. Does that really paint a picture of taking the risks of maternal mortality seriously, coming together as a team, getting creative and partnering with other folks to try to come up with some creative solutions? Is that like the perfect harmony?
I think it is up there. I will say that. It is up there. You know, I think that collaboration is really fantastic because it is showing that it's not only working at St. Louis, it's also working across the state in Kansas City. You know, and as Dr. Johnson said, this is not something that's new. This already exists in other parts of the world. I just came back from Australia, and I learned this actually working University Health. I had a patient who was Australian and told me the thing that she was going to miss the most about not delivering in Australia is they actually have postpartum group care. It's actually something that's organized, I think, by the state. And essentially they assign women to where they are in the pregnancy, and even afterwards, they basically create a support system for each other. And so this is not something that's new, but it's something that I think we could really learn from other communities about how we can try to be a group and not do this alone. And it's not just like doctors are trying to figure it out or people are trying to figure it out for themselves. We're going to do this all together.
Last one I have for you ladies is, you know, if there's someone who's watching, again, I'm sure a lot of expectant moms are on the Power Hour, maybe a few other folks, but what would your advice be for those folks who are watching and saying, man, this is a significant risk in the community? Maybe they got some education today they weren't expecting. What would your advice be for them on how to proceed, maybe in this pregnancy or a future pregnancy, and honestly, how to spread the word to other families.
Again, I think open communication is really the best thing. Dr. Johnson and Dr. Ruffin talked about validating experiences and listening and having these shared decision-making conversations. Finding a provider that you think, that you feel heard by, that you feel seen by, and someone that's willing to work with you, I think is the first step.
I think to also say that we're not only listening, but we're also paying attention.
Yeah.
Yeah, and that if there is something that's not working, that it is our job to figure out, well, it's our job to try to help and figure out a solution to it. I don't think the solutions always exist with us, as I've said. I think sometimes in medicine we pretend like we know all the answers, but we really don't. And the more you know about medicine, the more you realize there are gray areas. And I think that when I try to teach my residents and my fellows and my medical students, it's like sometimes it's okay to say you don't know. And I think patients really appreciate that. And sometimes it's actually good to say, well, what do you think? What do you think is a good solution? This is all the data I know. What do you think? And I think that as the more we ask that question of the people we're taking care of and serving, I think we're actually going to learn a lot more than we expect. So I don't know. I have to say that working here and working in Kansas City, I did some of my training in California and New York. I feel so lucky and privileged to be part of such an amazing community and to be learning so much.
That's pretty cool.
Yeah.
Well, Dr. Williams, Dr. Molly, thank you so much. And thanks, of course, to Dr. Ruffin, as well as Dr. Johnson from earlier in the Power Hour, the time, the knowledge, the expertise, and of course your hearts, just being transparent and chatting with us. We appreciate you joining us for the Power Hour here at University Health. It's all centered around healthy pregnancies, healthy mamas, and healthy families. Have a great rest of your day.